And we're always trying to improve medical care, and we're always looking for new therapeutic options, etc. So for colorectal cancer, we have several treatments, and while we do have different treatment options, we're trying to find out is one better than the other at UF.
And from a patient perspective, Stephen, would you like to comment on that at all about the importance of the studies?
Yeah, there were, for me, it happened to be that given the studies that going on at the time, because every study is not going on at every time. For me, my particular type of cancer, there was no study going on at the time. So I chose a standard option and went with that. But most of everything I'm going to discuss here tonight is applicable to both a standard type treatment or the one that we're looking at special tonight, which is research studies. So.
Okay. And I do want to remind everyone we will be taking questions live tonight during the event. So if you have something that you would like to ask, you can tweet your question via Twitter using the hashtag OCOH, or you can text us a question if you would like to do so. If you haven't already texted the code OCOH to 22333 to join our polling session, please go ahead and do that. And once you've joined, then you can feel free to send us your questions, and we will try to make sure that we get those answered for you. And we do have a question from an audience member. If you would like to introduce yourself.
I'm Sam Gaddy. I work for UF, work here at Health Street, the Cancer Resource Center. We run it at this point. But I think you touched on it a moment ago, but I'd like to know who conducts these research studies.
Okay, thank you.
So yes, I touched on it earlier. Again, it's usually you have faculty with part-time or full-time positions. They are the ones heading these research studies. And we also have professionals in training, example, or residents or postdocs or fellows, that they do conduct some studies which are usually minimal risk, like surveys or that have simple blood draws. So we do have our physicians that are usually heading these studies. There are also support staff members such as nurses and coordinators and managers such as myself, as well as physician assistants that also assist in study assessments and study procedures. And we do have a wonderful team of professionals that are helping to conduct all these research studies at UF.
I'd like to add something to that. Most of the studies, long before they're ever implemented, there's a whole vetting process that they go through to look at these studies. What's being done? Has it been done before? Can we leverage what's been done before and add something extra to it? So the studies from the National Cancer Institute, they look at them. I know Dr. George put forth several, and they'll go before committees and they'll go through them and they'll actually vet them, and it's very rigorous. So by the time they actually go to implement the study, it's been looked at by people who know a lot about it, and they're saying, yes, there's something to be gained by doing it this way versus that way.
Okay. We do have a question that has come in via Twitter. Are research studies only for people who have no other treatment options? And I think that's a great question. I think some people, Dr. George, might assume that this is something that you do when you've run out of other choices, but that's not the case.
No, not always. There certainly are some situations where research studies would involve a new treatment that maybe hasn't been used for that particular cancer, for the colorectal cancer, and the risks might be a little high, so it would be in a situation where maybe there aren't any other options, and a patient might want to consider that as an option. A physician might want to consider offering that as an option when there are no other good options available. But the vast majority of research otherwise involves making what we're currently know to be the best treatments available better, with less side effects or shorter in duration, or to otherwise optimize and improve patients' chances of being rid of the cancer or living longer and better as a result of the treatments. So they're not always involving just a last resort.
Okay. And Sinisha, do you find that most patients are aware of that or not aware of that when they first become involved with the question of whether to participate or not, or if they're eligible?
Yes, and we try to explain to them that yes, there are other treatment options, and physicians sometimes have a preference to prescribe one drug versus another, but there's no real evidence to say one is better than the other. So many of our studies we're actually comparing two medications to have data and evidence to say one is a better drug for whatever disease versus another. So we do try to explain that to the patients to help them to understand that yes, there are treatment options, but we do not know. We don't know which is better. So which is why we're conducting this study, to get evidence for a better treatment option.
Okay. Stephen?
No, it's one of those, like I said, it's one of those things. They're actually, by the time it gets vetted, they actually had to justify why they should be allowed to do this research. What is the benefit that they're going to gain from it? So it's not a trivial effort. They really make it, prove your case before we ever even put people or ask people to participate in this. We want to make sure that it's worth their effort and ours.
Okay. And speaking of the asking and the eligibility, how is it determined if a patient is eligible for a study? Dr. George, let's begin with you on that one.
I think it depends a little bit on the study, but every research study, any time research is being considered, there's always a very clear expectation of what type of disease, what type of patient situation would be appropriate for that treatment or for that research study. And so the eligibility or the type of situation when a study might be available for a patient is very dependent on the circumstances for that unique patient. Sometimes it is based on the stage of the cancer, how early it is or how advanced it is. It may be based on the location of the colorectal cancer. It might be based on what treatments have previously been used and whether they've been successful or whether they've not been successful. So there's a number of different variables that are taken into consideration. But in general, most research studies, especially for colorectal cancer, will involve some very minimum requirements, and that is that the patient is able to provide their own voluntary decision making of whether they want to be a part of that or not. And that's a very fundamental first rule. It's got to be voluntary. It also needs to be a situation where the patient is healthy enough to otherwise be able to take the treatments that are being used in the study.
Okay. And how is a patient approached, Sanisha? How do they find out that they are eligible, that they fall into that category where they could participate if they decided to?
Well, we usually meet the patients either in the hospital or in the clinic when they're being seen for routine care. And we review their medical charts. We look at their risks to make sure they are healthy enough to meet the study, because we don't want to cause injury. Yes, we're trying to answer a question, but at the same time, we don't want to cause injury to the patient. So we have very stringent criteria to ensure that this patient will qualify for the study. We review their charts. We make sure they'll be available for follow-ups because it's important if something happens, we should be able to reach them or have them come in for an assessment if necessary. So there are a lot of factors which we consider. We speak to the family to make sure they're also okay with it, because we need that support system if they can't drive themselves into the for a clinic follow-up. We need to have contact with a caregiver or a family member. So we take all that into consideration before we enroll a patient, and we do go through all their charts, medical records to make sure, yes, they qualify. This is the population that we're looking for, as well as to be sure to minimize risk to the patient if they are to be enrolled in the study.
Okay. And it looks like we have another question for the audience. Hello, if you would like to introduce yourself and ask your question.
Okay. Hi, my name is Asawan, and I'm actually a UF student. And the question that I have is, what factors should patients consider when deciding whether to participate in a colorectal research study?
That's a great question. Stephen, would you like to tackle that one?
Yeah. Communication is a large part of what I like to consider your own personal treatment plan. And by that, I mean the one that you need to sit down and develop and discuss with everybody in your support structure, your friends, your family, your spouse, your employer. And the first one starts off with communication is your treatment team. Okay, you're meeting all these new people. You need to get a spiral-bound notebook. I mean, start writing down names and phone numbers and making sure that if you get a question later on, you can write that question down. So when you come back to your next appointment, or if you have an opportunity to talk to them, you can ask them the question and get that question answered right then and there. And just remember that all these, and especially about terms, okay, all these new terms are going to be thrown at you, write them down. Ask your treatment team. Find out what these words are, because the more information you have, the better you're going to be able to handle, quite frankly, the anxiety that's going to sometimes come upon you. And you need to be able to have that information ready, communicate, talk to them, make sure you got that in place. Employer, make sure you know what your employer's flexibility is. Talk with them, communicate, find out what's going on. There's a Family and Medical Leave Act that's available for certain employees, to where you can have up to 12 weeks of unpaid leave with a guarantee of not losing your job for certain employees. Find out what he can do. Find out if that's a part of what you can consider, okay? Then you hit your family and friends. Are they going to be there for you? Who are they? Get their phone numbers. You don't want to be figuring this out at 2 a.m. in the morning, all right? You need to get all this stuff figured out way in advance. You have to plan. Planning helps helps you to deal with all the other things that are going on in your mind, because you got to realize it's coming at you like a freight train. It's like all this new stuff is like trying to take a sip off of a fire hose. It's just coming at you, and you're already trying to deal with the cancer word in your life, all this other stuff coming at you. Write it down, communicate, talk with people. Then you get to your the actual treatment schedule. Okay, what is it? How long? Find out what it's going to be. That way, when you get with your employer or your family or friends, you can talk to them about how long you're going to need them there for you to help you out. What's the location of the facility? Is it local? Is it a commute? Is it a plane flight? Is it overnight? Get the logistics figured out. Sit down and come up with all that stuff. Side effects. What are they? They can tell you what the major side effects, the ones that they know about, are, but we're all different. All right? You know your body better than anyone. Make sure that if you start feeling something that's not quite right, you communicate. You get your treatment team involved. You write it down. And don't treat it like it's going to go away. You know your body. It's new, it's different, and you're taking this stuff. Make sure you don't wait till, again, 2 a.m. in the morning to figure this is not going away. And your only alternative at that point maybe is the emergency room, where if you had called them early on, they could have probably gotten you something over the counter or something easy, some treatment, and could have headed it off way ahead of time. And these considerations, I mean, you've got to get on top of them, and you've got to get that little spiral-bound notebook and get yourself educated as best you can, and just get involved. I know there's a lot of things coming at you, but get involved, and communicate.
And Stephen, you mentioned anxiety a little while ago, as well as your treatment team, and we have a Twitter question that relates to that. If I participate in a research study, who handles my care? Do I see my regular doctor? And you have a very good relationship with Dr. George, and we hope that all patients would have that, because that relieves some of the anxiety, I would think, having that relationship. So Nisha, would most patients be able to stay with their regular doctor if they sign on for one of these studies?
Most of them would, because you're approached by your regular doctor to be in the study.
Okay.
And most times the doctor is a part of the study team. So most of them would be seen by their regular doctor if they participate in a study. For some of the follow-up visits, you may have another, a colleague that may assist the regular doctor for follow-ups and things of that sort. But usually it's the regular doctor, and we do collaborate with your primary care physician on your care. So whatever other physicians you are seeing, we send a letter to let them know that yes, you're in the study, and this is why you're in the study, and whatever medications you're taking. And we provide contact information for that doctor to call us if they have any questions at all, or is there some drug the patient should be avoiding while they're in the study. So we do collaborate on care with everyone that's participating in that patient's healthcare, and the patients, we make sure the patients are comfortable with all the decisions that are being made, and there's communication across the board of all doctors.
And kind of a follow-up question to that, which is also which came to us through Twitter: am I allowed to change my mind if I decide that I don't want to be in a study any longer? Is that a possibility?
Absolutely. It's completely voluntary. At any point that you've decided to participate in the study, you can change your mind for whatever reason and say, I don't want to participate anymore, and you are allowed to leave the study. We do ask, however, that you contact the study doctor before you stop taking the drug, so they can advise you on how to get off the drug safely. Maybe they have to wean you off. So we hope you don't stop taking the drug without letting us know. We usually have a good relationship, and we explain that to them. If you don't want to be in the study anymore, just let us know, and then we'll wean you off if necessary, or we can switch you to another medication. That way you're still being covered for whatever you're being treated for.
Okay.
But it's absolutely voluntary, and you can decide to withdraw from the study at any point.
Okay. Dr. George, we know that minorities are underrepresented in cancer research studies. Any thoughts as to why that might be?
Well, I think there's a lot of different reasons why why all patients are underrepresented in cancer research, but in particular minorities. We base all of our clinical decision making, all of our practices off of only 2% of all cancer patients in the country enrolling on clinical research currently. So there is a huge gap between what we do in clinical practice and what we know to be the best care, but part of why our advancing of the science of making things better for everyone is limited is because we really have not only a disproportionate representation of people who are who participate in clinical research and research studies, but there are disparities in those who do. So it's 2% of a small number is already a small number.
Is there anything that can be done about that?
Well, there's lots of things that are actively being done and pursued. I think one of the most important things that has been done recently is the provision that if you participate in a clinical study or in a research study, that all of the aspects of your care that are otherwise considered standard must be covered by your healthcare provider, must be covered by your insurer. And with the Affordable Care Act and with more universal coverage happening for everyone and being available for everyone, that is increasing, I think, the ability of a lot of folks to participate in research that otherwise previously might not have.
Okay.
So that's a very important, improvement, I think, overall in the system.
And very encouraging. I'd like to take some time to think about some of those more personal aspects of the process and the journey. And Stephen, if you would share with us a little bit about your story, your diagnosis, and what that was like for you.
Well, when I first got diagnosed, it was rude, and it was overwhelming at the time, because I came out of a routine colonoscopy, and basically I'm coming out from under the medication, and they, boom, dropped that on me. So it was a challenge. It was a challenge to get my head right, to get my head around it, and basically I just didn't hesitate. I said, well, we just need to go with whatever needs to be done. Let's just start it right now, because backing off, it's not going to help a single thing. So I just pursued it as hard as I could.
Okay. And from that point, what sort of treatment options were you offered?
Okay, there were no studies going on for my particular type of colorectal cancer at the time. So Dr. George, I consulted with him, and he basically said, well, and they looked at I had a whole bunch of ultrasounds and tests and everything of it, so that they looked at all my blood chemistry, and they looked at all that and said, okay, we've seen this before, this is what it is, this is how far along it is, and given that, as he indicated, or given that particular thing, this is the best course of treatment, the standard treatment that we can go with. And so I said, well, let's go with it.
Okay. And Dr. George, what is it like working with patients, especially during that early phase when they're just coming through understanding the diagnosis? What is the best thing that a doctor can do to help them along?
be patient and be available, because as Stephen alluded to earlier, I mean, that spiral bound notebook, that's not just if you're considering a research study. That's for anybody facing what's going on, because there are a lot of questions that come up. There's a lot of information that you don't think about until the drive home, or until 2 o'clock in the morning when you wake up. Yep. And you need to have a way to inventory all of that, write it down, and have it ready for the next visit, for the next appointment, and really be able to get your questions answered. I think knowledge is power, and that's part of what empowers you to be able to ask the right questions and do the right thing for yourself and for your family.
And Sanisha, is that an important part from your perspective, is helping patients understand how to advocate for themselves?
Absolutely. I ensure they understand what their options are and why they're being asked to be in the study and what will be required of them to be in the study, and again, the benefits, if any, and the risks. And I also have them to tell me back what you think the study is about. Do you understand what the risks are? Because it's very important. And I also give them my card, my number, to let them know you can call me for whatever question you have, and don't give consent to be in the study until you're absolutely sure, you understand what the study is about, you understand all the risks, you understand all the visits that we're asking you to come in and participate in.
Okay.
So it's an ongoing process. And again, since they can change their mind at any point, they ask questions as they go along as well.
Okay. And it looks like we have a new Twitter question available to us that has just come in. How long do studies last, particularly colorectal cancer ones? Dr. George.
I think it depends a little bit on the situation and the research study. For a lot of patients who are involved in research studies where the cancer is curable, there's a very finite period of time, very limited period of time where the treatments would be used to get the cancer gone, essentially. And then there would be maybe not so much in the way of treatments, but follow-up. Continue to keep an eye on them, checking blood work, checking x-rays, checking in on them, on the patients, to make sure that everything is going as expected. So the actual treatment may not be very long, but the ongoing follow-up and surveillance might be a couple of years. For patients who have incurable cancer, in general, the treatments last for as long as they're working. There's really kind of 3 rules. It's until the treatments no longer work, in which case medically there's not a reason to continue them. The treatments work so good that the cancer goes away, in which case that's the best case scenario, and that's what we're all hoping for. Or the third case is where the patient says, I'm not interested in doing this anymore for whatever reason, and they can pull the brake cord on it at any point in time. So there's medical reasons why the treatment would stop, and there's patient reasons why the treatment might stop, and those are all and both happening at the same time.
Okay, so that's how that works. And another question via Twitter that has just come in to us. What kind of lifestyle changes could you expect when you sign up to participate in a study? That's a great question.
Well, I looked at it, because you start looking. The first thing, if it was coming to me, I would be sitting there going, okay, what can I realistically expect from the side effects? In other words, are they typically, for lack of a better word, debilitating type side effects, or are they something I can live with? And everybody's different. So you're going to have to be aware of them, and you're going to have to make sure that you've already talked with your employer and you said, hey, they're saying I might have this, and you've got to have that's why that plan is important, to be flexible. So as you're going along and you're communicating, and maybe I was very fortunate. I had very few side effects or things I had to worry about, and I was basically my lifestyle didn't change relatively little at all, other than missing out on going to work a couple of days. Just some days you just not up to it, right? So I missed a couple days of work, but most of the time, even with the radiation and everything else that I was going through, I I had very few. I was fortunate. I had very few side effects.
Now, as you went through the process, we've talked about having opportunities to make decisions about your treatment. Well, did you have to make any decisions about yours? I know you said for the most part, the doctor said this was the best way to go, and so that's what I said to do. Did you have to make any decisions along the way?
The only decision I had to make along the way were more, not about in terms of the plan. No, most of the decisions I had to make along the way were psychological decisions about how this was going to hit me, what I was going to do. Did I believe that because I'm an overcomer, I'm 33 years retired Air Force. I'm going to take that hill. I'm going to go, and I'm going to push hard. And because I want to. I looked at my wife and my children were more, I think, were almost more devastated than I was. Okay. And so that had to be part of what I was looking at. That had to be part of my communications. Going back to what we were talking about earlier, which is that spiral-bound notebook and asking questions. Half of the questions I asked were questions my wife and kids were asking me. Well, what about this? And sometimes they'd ask me questions and I'd go, oh, I didn't think about that. And so then I'd put that down and I'd go and I'd get an answer. I'd go to my treatment because my wife has done told me go get an answer for this. I don't know. Been married 40 years. I know better.
There you go.
So, but she was a good support team. I had a great support team. I had people that were there for me. That they were sometimes I think more worried. They were more worried than I was, and I think make sure you take care of that. Make sure you feed back to them. I'm okay. Yeah, I'm gonna have a little rough day, but this is one of the few. I'm okay. That's good to go. Things are going good. The doctor's giving me good reports. Let's and so because they need that. Because don't leave them in the dark. Keep them informed because they are just freaking out worse than you are. All right, just.
Well, how did you get involved in being a patient advocate? Was that a result of all of your own experiences making you feel like I've got to do that for somebody else?
Yes. That was my radiation treatments. I would go in for my radiation treatments and I would run in, because that's usually when you go there is where other people are coming in, right? When you're taking your chemo, unless you're getting it infused into you, typically it's oral or whatever. But I had an opportunity to observe children going in for their radiation treatments. And as I reflected on that and thought about, man, what would I have, I mean, I know what I'm thinking, but if this was my kids, what would I be thinking? What, it was like, whoa. And I decided at that point that when I'm learning all I can from this because I'm going to come back and I'm going to do something, I'm going to add something positive to all of what's going on here. I've got to. I see this and it wells up inside of me almost to tears that I've got to do something. And so Dr. George offered me an opportunity. I don't know whether it's because I was hard-headed or what it was, but he offered me an opportunity to participate on one committee, and I participated. Now I'm on 2 committees, maybe three now. And I don't know whether it's because I'm willing to do it, but that's fine with me because I want to get there. And if I can make, like I told you earlier, if I can go out there and make a difference in one person's life because of what I've been through, then that's what I want to do. And it is overcomable. You can do it, so just stick in there.
There you go. That's how it happened. And now we are going to change gears a bit. We've heard our panel talk about some of the challenges that people might face when they're making a decision about their care. But how does that play out in real life? Now, the UF Center for Arts and Medicine has prepared a brief performance showing what these conversations sometimes look like.
Hello?
Oh, hi, Leah. Have you got a second? Did I catch you at a bad time?
Come on, Pops. You know there's never a bad time for you. What's up? How are you doing?
I'm okay, considering, well, I'm a little tired with the treatments and everything.
Yeah, I bet. Is Mom still making you those green smoothies you like so much?
Yeah, yes, she has. They're actually quite good. Leah, I was wondering, are you busy on Thursday?
Well, I'd have to check my calendar, but I think I can probably break away for a couple of hours. Why, what's up?
I had a visit with my oncologist last week, and, well, she suggested that I opt into this study at the university.
Really? A study? What kind?
Well, it's for people like me who have pretty advanced cancer, and it's some kind of a new protocol. It's a big decision, and I'm thinking I could really use your smarts to help me discuss it with the doctors.
Dad, you know that I hate hospitals, and you know I don't like getting involved in your decisions. But what are you worried about?
Well, the study involves trying some different chemo combinations and not undergoing radiation.
That doesn't sound like a very good idea to me. From what I know, radiation is really important. Do you really want to jeopardize your treatment like that?
You see, this is exactly why I need you to come with me. Your mother doesn't know anything about these things. I need your help, and I need you to keep me straight.
But I'm just not comfortable with this, Dad. You know that.
I know, but Leah, it's serious. This could be a game changer. What would happen if I start the study and it doesn't work? Do you think I could go back to my regular treatment?
I don't know, Dad. They would have to tell you that. I can't. And will they tell you if you're in the group that actually gets the new treatment? Because sometimes they don't.
I think so. Is that what open label means?
I'm not sure.
Yeah, Leah, come on. A couple of hours is all I'm asking.
Okay, Dad, I will make the time. When should I pick you up?
Well, after lunch should be good. Leah, thank you.
You're welcome, Dad. I'll see you on Thursday. I love you.
I love you too, sweet pea. Bye-bye.
All right, I'll talk to you later.
So a real challenge there for Leah in talking to her father. She clearly wants to help him and clearly loves him, but just doesn't know what to do. Dr. George, it would seem to me that would be common in just about any family.
Yeah, I was already kind of playing through my mind. That was the scenario from several patients last week. So, yeah, it's a very common occurrence, and it's great that, you know, in that scenario he was willing to ask her for help, and she let him know that where her boundaries were with her comfort level with it. But at the end of the day, his support team came through, and they're gonna get together and talk it through and figure out what the right thing is for him.
Okay. We have had someone tweet us a question, are all research studies the same? And I think that's really helpful here to transition us into the discussion about research study design. And we have already discussed this to some degree, but could you answer that question for the audience? They're not all the same, even if they're all dealing with colorectal cancer research, for example. Is that correct?
Oh, that's very true. Yeah.
Sanisha, would you like to take that one?
Sure, well, I can start. Yes, they're not always the same. There are different risk levels. If it's a new drug, of course, there's not much information about that, which is why we're doing the study. If it's an old drug, maybe for a new indication, like Dr. George mentioned, maybe it worked in another cancer, now we're looking at colorectal cancer. Or it could just be, surveys where we're following up on patients or doing chart reviews. So it depends on what question the investigator is trying to answer and what information is already out there. Sometimes we can find what we need just by reviewing patient charts, and the patient will still need to give us consent to do that. So they will still be participating in the study, even if we're just pulling information for whatever their standard care is. It's just there's a myriad of ways we can conduct cancer studies or any clinical studies.
All right.
Every research study, like I said, it gets vetted. So unless it's going to provide some benefit, that is, it's something new, something different that's never been tried before, it's not going to get approved. And usually there's already a set number of people, that's what they call an accrual. Once they hit a certain number of participants, it'll stop at that point, and then they'll start doing looking at the data that they've gathered to try and figure out, okay, what's our next step with what we've found out so far.
Okay. And it looks like we have another question from our audience. Hello, would you like to introduce yourself and ask your question?
Hello, my name is Millie. And first, before I read what was on the card, I wanted to thank you for your service in the military and your continued service as an advocate. Thank you. My question is, if I'm part of a research study, is it possible that I won't get the same level of care as a different patient?
Dr. George?
That's a great question. So being in a research study, I would argue you actually get double the more attention to detail. So what happens when a patient volunteers for a research study, if it's a research study that involves a new treatment or a change in the treatment, is that they, as Stephen alluded to, there's already a vetting process, a scientific process, a safety process that goes into knowing that that is at least worth and safe to consider doing. But more importantly, there's, in addition to your doctors and your nurses and all of those individuals that would be part of your regular cancer treatment, you also have this entire second team of researchers who are looking over their shoulders, making sure that all the I's are dotted and T's are crossed and that everything is being done exactly the way it needs to be. And so you've actually got two teams working on your behalf, even if you're getting the standard of care, even if you are receiving treatment that you otherwise would normally be getting otherwise, but just as part of a research study.
Thank you. If I may, just one more question. Sure. You were talking about a disparity as far as minorities being represented, but as we all know that unfortunately there's a lot of work, whether it's daycare work, as a cashier at McDonald's, as a nurse tech, that doesn't have very good medical coverage, or some that don't have any at all. And if you're underinsured or not insured, are you still able to receive and be a part of a research? Is that still available to you?
That's a great question.
Well, that's a very good question. Yes, you can still participate in research. We don't discriminate based on your insurance coverage. I think one contribution to the disparity is that people without insurance, they don't have access to quality health care. And it's within that hospital or clinic is when we approach patients. So already you can see that, many patients are getting left out because they're not coming in to see a physician where they can, hear about a study, which is why I think Health Street is a wonderful program that goes out in the community to identify patients that we would have otherwise missed because they don't have they don't have access to quality health care. But not having insurance, it doesn't, for most studies, it won't prohibit you from participating in a study.
Thank you.
Yeah.
Thank you. And we're going to move on to the topic of information seeking and have a discussion about decision making. Let's talk about where people can find information about research studies. And we did have one question come from Twitter related to that. We had someone ask us, is my doctor the only person who can recommend a study to me? Dr. George, is that how it always happens?
No, it's not. So your doctor may be the usual person that could recommend a research study to you, but it's not always the case. There are several opportunities and situations where other members of the healthcare team would be looking over everyone's shoulder to make sure that all options were on the table for patients, especially at a university system or university setting. And so that's where research coordinators and research managers and others might approach a patient alongside the physician or alongside the primary care team and say, there's something that might be also worth considering.
Okay. And we have another audience member ready to ask a question. Hello, how are you?
Hi, my name's Katie. I'm a Gainesville resident. I think just to follow up on that, are there places to find information about research studies outside of just, hearing from my doctor?
That's a good question.
Yes, the CTSI, the website ctsi.ufl.edu, you can go to that website. There's a community section that lists all the research that's going on at UF. And if someone is interested in participating in a study, they can go ahead on the website and search for research studies that are appropriate to whatever condition you may have that you're interested in having participating in a study for. You can also go to clinicaltrials.gov if you're interested in being a part of a clinical trial. And I've had patients who simply Google, whatever condition, and then they'll call me from all over the state saying, I have this condition. Is there anything going on that I can participate in a study? And there are a myriad of ways that people can find out about studies besides in the doctor's office.
Okay, good. And we have a new tweet available to us. Oh, I'm sorry, go ahead.
No, it's okay. I would caution against the Dr. Google part. There are some very reputable sources out there for finding out about research, but research that's been appropriately scientifically vetted is appropriately approved for kind of moving the science forward and helping patients in the process. And so that would be really what is available through the university or organization that you're affiliated with, as well as the clinicaltrials.gov. So if you're interested in participating in a research study that involves a new treatment or some modification of a treatment and it's not listed on clinicaltrials.gov, that's a big red flag. They are required to be on reported on clinicaltrials.gov if they have been appropriately vetted and reviewed.
Okay, so a word of caution there in terms of how you go about reaching out to participate if you think you're interested.
And the question is, when they do a research study, it's not just available in one place. There can be several universities that are participating in the same study, so they're getting participants from different parts, potentially different parts of the country. So just because we're doing it here at UF doesn't mean it's the only place it's being done. It could be done other places. That's why it's important for you to, as I indicated earlier, to find out where that treatment is going to occur and figure out your logistics to get back and forth.
Okay. And a related question to that is study membership patient or provider driven? And can we use social media to help drive participation? Can that be an approach to maybe finding participants possibly?
Possibly, but we do need approval from the university, the institutional review board. We can't just advertise without proper authorization given to us. But yes, we can use social media as well as other avenues of advertisement to find patients for research studies.
Are there patient groups or organizations, Stephen, that can help patients make their decisions as they consider or go through that process? What would you recommend as an advocate?
Well, first off, if you've been contacted by a physician and they're approaching you to be a candidate, right? One of the first things you can say, okay, has there been a group set up? Is there a group already formed right here that's all the people that are participating here at UF? Is there a blog? Is there a social media site that has been established where we can all go there and sort of share, hey, this is what happened to me, be aware of that. There's also, the internet's a very powerful thing. You can go out there and you can find more blogs and more groups. You can actually find out, once you know your particular type of cancer, you could go out there and research yourself and see a lot of the classical treatments for it and prognosis, and once you have all of your information so that you can educate yourself. We were talking about knowledge is power, and you can find out, okay, if this is what they're offering me as a standard treatment, what can I do? What's going to be the benefit of going with this? And what groups are out there? For instance, I know breast cancer here at UF has a very large local group, very active. There are other different, I've only heard about that one in my group, but there are other ones that get formed specifically because people have questions. People like me that want to go out there and start a blog or start a website, they get out there and they start making things happen so that people can talk and communicate and share and help one another through it.
And Dr. George, we hear a lot about this idea of personalized medicine when it comes to healthcare across the board and probably every aspect of our life when it comes to our health. Is that something that, what does that mean in the context of colon cancer treatment? Is there a place for personalized medicine, so to speak, in what you do?
Absolutely. So personalized medicine for colorectal cancer is, well, it's a bit of a misnomer because all cancer is very personal. It's personal to the patients, personal to the support system. And so when we talk about personalized medicine, it's not to take anything away from that. But what we're really talking about in the scientific term is being able to tailor the treatment more specifically, either to have a better outcome for the patient or to tweak the treatment in a way that takes certain considerations into play that are unique to that individual patient. So how their body is going to react to a certain treatment. Are there going to be long-term side effects that otherwise could be avoidable? You know, other things that go into that. So that's what we really talk about with personalized medicine. And in the era that we're in today of genomic profiling and deep mutational sequencing of tumors and pharmacogenomics and all sorts of other aspects of scientific discovery, we're just finally starting to chip away at really getting at not treating a patient based on this is their cancer, how it looks under the microscope, but this is how their cancer behaves. This is what we can predict about their cancer and head it off at the pass.
Okay. So, an exciting time to some extent in terms of what the future might hold for treatments and for cures. And let's move on to protection and participation. A lot of patients have great concerns about safety, and we haven't really addressed that issue yet. So we have an audience member who has a question that I think might be related to that. So if you'd like to say hello and introduce yourself.
So hi, my name's Dorothy, former UF student, and I'm just wondering, all this information is great, but how do I know it's safe for me to participate in a research study?
Well, like Stephen mentioned, each study is vigorously vetted by a board of experts. These are scientists, physicians, radiologists, pharmacists, experts of ethics, and they each review the study for merit, scientific merit, as well as risk of injury to patients. And they will not approve a study unless the risk is minimized or adequate provision has been made for any risk of injury to the patients. Also, before you consent to be in a study, we do, inform you about all the risks that are potentially involved in being a part of the study before you decide to participate in the study. So we try to be as safe, try to minimize risk as much as we can. And, before an investigator recruits patients, this board has to approve the study as well as re-review it periodically to ensure that if there's new information, the patient is not being withheld treatment, that could improve their care, as well as if there's any injury or any adverse events, then we inform the patients that this is a new event that we weren't aware of before. So we do keep you informed, and we make provisions in the case of an injury, how we would handle that treatment of whatever condition that arose from that.
I'm glad you addressed that. We had a Twitter question also about that specifically. What happens if someone becomes injured or during a study or reacts badly to a study drug? Dr. George, is there anything else that you would like to add to that in terms of how that would play out?
No, other than that we would do everything we can to take care of the patient regardless of whether it was due to something associated with the research or something just associated with the general care of their cancer. I think the other important part is that there's also patient input into this scientific review and this pre-review process, and that's a great opportunity for patients to get involved. That's exactly what Stephen does. He's part of that vetting process now with the NCI to say, well, how much risk is really risk when you're talking about not a theoretical risk, but a real risk to a patient who's been there, done that.
And an audience member also has asked via Twitter, how likely is it for me to become injured or sick during a study? Is that very common or is it uncommon?
Everybody's different. Everybody is different. If you sit down and you read some of the medications that over-the-counter medications that you take today, and they list all the possible things that could happen to you, all right? You're like, why would I? Okay. And that's the same problem that question entails. Is everybody is different. Everybody's chemistry is different, and so. What affected me, I developed a symptom after long term. I had one particular side effect called hands and feet. The chemical was so smart, it was attacking all the rapidly dividing cells in my body, which is typical of cancer. Well, the problem is your hands and the soles of your feet are also replacing at a very high rate, okay? So I was engaged, and I called as soon as I saw something, and he said, and he adjusted, and we moved on. And that's why the communication has got to be there. You've got to be engaged. They can't anticipate everything, but if you got that spiral bound notebook and those phone numbers and those people's names, and you know what to do, and you've already got your contingency plans in place, it's a reasonably good plan and a reasonably good way of approaching it.
I can hear that conversation now. Dr. George Stevens on the phone. Stephen, what are some of the common reasons that people do decide to participate in research studies?
As Dr. George indicated earlier, the worst case scenario, of course, is that there's no other treatment available for that particular type of cancer. Another one could be this particular treatment says there's no surgery, or this particular treatment says there's no radiation, or this particular treatment might provide some benefit to you, and that's something you have to really, really look at, and because 2 a.m. in the morning, you have to have already decided that this was a good idea and that there's a benefit and that there's a light at the end of the tunnel, and you know why you're doing it, and you know what's going on here, and you're engaged and you're informed, and you got to have all that going for you before, and you can do it. And that's why you would participate, as you see something in there for you.
And for other people too. Some people do it thinking this might not cure me, but it might cure someone else.
For the common good. There are people that, because sometimes, depending on what they inform you about what's going on here, it could be, well, we're using, the standard treatment uses drug X. Well, this treatment's going to involve drug X plus drug Y. So we think that there's a benefit in there in terms of maybe your treatments. There won't be as many treatments. It won't be for as long. There's a lot of factors and a lot of moving parts, but you sit down there and you take your notes and you figure it out and you decide whether this is something that you really want to go after, and hey, this looks good for me, and I'm up for it.
Mm-hmm. And Dr. George, sometimes some patients decide not to. Are there any particular reasons that might happen?
I think if the logistics of the involvement with the research project or the research trial is too onerous, that can certainly be a barrier. If childcare is a consideration, if the support system around the patient is not particularly strong or suitable for what the requests are on the patient. We see the same challenges in patients who are not on clinical research or not involved in research studies. So life is complicated.
Yeah. Right. There's no better way to say that. Life is complicated. And we're getting near the end of the discussion, but we wanted to make sure that everyone's questions were answered who's here tonight. If there are any other questions from the audience, we'll be happy to take those now. And for Dr. George, for Stephen, or Sanisha, if there's anything else that you would like to ask, please feel free to do so.
I was wondering, is there a review?
Oh, could you come up to the microphone? I'm sorry. I should have asked you to do that.
Forgive me. I was wondering, is there a review board? I know you talked about, the ethical committee and all that, but say, for example, you're in the process and you feel that as a patient, you're more of a guinea pig than a patient and you're not being treated with a level of respect. Is there a hotline or a form that you can fill out to have your case or your situation reviewed or looked at? or maybe request someone else to be assigned to your care?
Well, if there are concerns, we do provide a number where the patient can contact, to express their concerns that does not involve the study team. And it's written in the consent form. So yes, there is a hotline provided for each patient, and they're free to call, and it won't affect their care at all.
Good.
They still receive their standard care. And if they decide not to be in the study for whatever reason, they can also do that as well.
Okay. Well, thank you so much.
I'd like to add something to that. Whether you're going in for whatever reason, anytime you're getting any medical treatment, whether it happens to be a research study or it's going in to have a splinter removed from your hand, okay, you are empowered as a patient, all right? You can ask for anybody that's in that room that you don't like or you don't feel like they're giving you the type of care you need. You can ask them to leave and bring somebody else in to get you the treatment that you want. It's about you. You need to stand up. You need, don't be, that's what no. I mean, you can't be sitting there and because you can't go home and think to yourself, I should have. You got to do it right there, right then, because you want to go through this one time. I don't care if it's getting a splinter out your finger or anything else. You want to go, and if you've got people involved in it, like Dr. George, if I had to take something like that to him and say, I don't think I was treated right, and they're engaged, things are going to happen. You've got to be there, and you've got to be there for yourself and make sure that you're getting the best that there is, because you want this ride to go as smooth, and you don't need attitudes in there that this is no place for attitudes, because that treatment team signed up for this. They knew what they were getting involved in. They know the challenges, and I know that we all have rough days, and we all have those days where the car didn't start, we all can get through those, but I'm the patient. That's right. The world's circling around me right here.
And if you don't get the help you need from yourself, call Steven, and he'll take care of it for you. You should start your own business. We do have one more Twitter question that we'd like to get to as well. We want to make sure that everything gets answered tonight. How many different types of colorectal cancer are there, and how many of them have research trials available?
So there are 4 stages of colorectal cancer, with stage 1 being a very easy to remove colon cancer that doesn't usually leave any permanent trace of the cancer and doesn't require anything other than just simply removing it, all the way to stage 4. So 1, 2, 3, and 4. And stage 4 colorectal cancer is usually incurable, not in all patients, but for, unfortunately, the majority. But there's also several other, so there's research that's available, research trials that are available for all of those different phases and stages of the cancer for patients with those diseases, as well as cancer prevention studies, cancer survivorship studies, and different studies that involve the cancer looking for and helping to develop this personalized and precision medicine approach to knowing more about the cancer and for us to become smarter about how best to treat the cancer for the individual patient.
And we do have another Twitter question. They're coming in fast and furious. How many people are needed for a cancer research study? That's a great question. Could it be 10? Does it need to be 100?
That's a question. That's a question that gets determined when the study is first submitted. There's a whole process where they determine what the numbers that they're going to need. It could be 400. It could be 1,000. It all depends on what they're looking at and all the different, because they call them different arms of the study. One part of the study could be using these 2 drugs. Another part of the study could be using just a single drug. So there's, depending on how the study is set up, it could, you could need different number of candidates to accrue the number that you need to really look at the study the way that it was designed in the first place.
And statisticians are involved in the whole designing process of each study, and it depends on what the investigator is looking for. If it's a 20% improvement, etc., the statistician will let you know, well, you need this many patients. We account for some that may fall out of the study, but we still try to have as little, as few people that we need to answer that question. That way we're not enrolling too many patients that we don't need and placing them at risk if there's any. So statisticians do help us to find the number, a good number that we need, and that can vary from hundreds to even thousands. It just depends on what they're looking for and what improvement they need.
Now, Dr. George, are there some studies that are based on patient records where patients don't necessarily even have to be involved? I know you mentioned cancer survivorship, for example. Would that be something where you could look at a population of people who have been treated a certain way or with a certain treatment and then determine survivorship rates just based on records where the patients are not directly involved at all in that kind of research?
Yeah, absolutely. If the research involves no significant risk or very little risk to the patient, to the individual, and sometimes this scientific vetting process and the IRB, the Institutional Review Board, will say, you know what, you don't need to get the individual patient's permission because this is information that's already out there in the public records. So, for example, if the if just knowing if a certain population of patients have done well with treatments, but that can be gleaned from hospital records that don't involve knowing who the individual patient was, but looking at a group of patients where it's anonymous and it's de-identified. Then that research could be done without involving the patients or bothering the patients. But certainly that information could help the next group of patients that come along.
Right, and that kind of goes back to, Stephen, what we were talking about earlier with the fact that some patients might make a decision to be involved, not just for their own sake, but for the sake of people down the road. Maybe it's 5 years from now, or maybe it's a generation from now, that you could be helping someone by becoming involved.
That's what, like I told you, that's why I got engaged, and I just made that decision. I thought it was important because I figure if going through or helping to go through saves someone in the future not having to go through any of this, then sign me up.
Yeah.
Let's go.
Good for you. We do have one more Twitter question that we'd like to get to. What is the prevalence of colorectal cancer? Who is at risk for colorectal cancer, Dr. George?
So about 1 in 7 Americans have the risk of developing colorectal cancer. It's most common beginning at the age of 50, so it's a cancer that is not typically found or isn't usually a concern until after the age of 50, which is why most primary care doctors recommend that beginning at the age of 50, you start to get screened for colorectal cancer. So, but you have, if you live long enough, you have a 1 in, which is to 50, which is not that long, the older I get.
That used to be a long time.
Yeah, but 1 in 7 chance of developing colorectal cancer. And the frustrating thing about it is that it's otherwise completely preventable for the vast majority of patients. That number could be a whole lot smaller, a whole lot lower if everyone was receiving the recommended screening tests to identify it early when it's that stage 1 and get it out of there easily, or prevent it from happening altogether.
Okay, and prevent it meaning?
Meaning getting a colonoscopy or some other test to detect the pre-cancer, the thing that starts off developing into a cancer if left there for too long.
Okay.
And that's completely, patients and individuals have no way of knowing that it's there. They won't notice any blood, they won't notice any change in the bowels, nothing at all, even if you're super in touch with your body.
Okay. And we often think that we are maybe more so than we really are.
Yeah, well, Stephen, you said it yourself. You woke up from the routine colonoscopy and wham, there's the news.
Yeah, and now it's like, get over it. Go out and get it done. Just because you don't know it doesn't mean it's not there. I mean, you can't just keep walking. You can't ignore it, and it's not that big a deal. It really isn't. I mean, these people are good at what they do. Go in and get that colonoscopy. Just do it.
Just do it.
Just do it.
And one more audience question, and again via tweet. Is there research about how minorities react differently to cancer research, or are there findings about it? That's a great question. Dr. George, how do you answer that one?
It's a great question. So part of the challenge in answering that question is that because there have been so few minorities involved in colorectal cancer research, it's hard to know exactly how those individuals differ from other patients who've been involved in cancer research. So the more involvement everyone has in cancer research, the more we'll know how best to approach individuals. And individuals regardless of race, regardless of age, regardless of gender, regardless of ethnicity, regardless of hair color or eye color or anything else. I mean, it really is going to boil down to how is that individual patient, that one person, to be treated, not a population of people.
Thank you all so much. And unfortunately, we are out of time tonight. However, we will continue working to find new ways to help people find the information they need about cancer research studies. Before we end, we want to know what you would find most helpful. You can text us at 22333 and tell us what you think. Type live if you would like to personally participate in a town hall in your community. Type webcast if you would like to participate live in a town hall through the internet. And type video if you would like videos that you can access on the internet. Type info if you would like to read news and other information on a website. And for our web viewers, please let us know what you thought of tonight's event by taking a short post-event survey. Please use the post-event link that's found under the surveys heading on the live stream page to participate. And thank you all very much, audience and panel members, for being with us tonight.
Thanks.